everyone. On behalf of the Government Medical Officers Association and the Society for Research and Innovation, I warmly welcome all of you to the Medical Documentation CPD Program 2021. This is our 13th CPD program. This is a one-hour workshop which is done by Dr. Harsha Sathishchandra, the President of the Sri Lanka College of Internal Medicine and consultant physician at the National Hospital of Sri Lanka. Please be kind enough to mute your microphones and turn off your video cameras during the workshop. And if you have any queries, you can direct them to the panel of lecturers in the chat box. Now, I warmly welcome Dr. Harsha Sathishchandra to start this workshop. Over to you, sir.
Sri, for giving me this opportunity to speak on a timely topic, and I'll be sort of limiting myself to about 45 minutes in the discussion of the topic, and we'll leave enough time for your questions. But while I deliver the talk, if you have any burning issues, I'm willing to answer those questions as well. Yeah, now this is obviously a timely topic because COVID-19 is quite widespread now, and it has become a huge problem, not just medically, but economically and socially as well. But you might ask me, why focus on treatment in this era of vaccines? Now, we know that vaccines are being rolled out globally, and here in Sri Lanka, close to 1 million vaccines have been given. So why focus on the treatment? Now, vaccines, of course, take time to develop, and they have to be tried out. And there are serious issues with production and distribution of the vaccines. And even now, globally, not many vaccines have been rolled out, and only a small percentage of the people have been vaccinated. And sometimes, due to emerging strains of mutants, we may have to use second or third generation vaccines as well in future. And what that means is that to get adequate coverage to achieve herd immunity, it will take a long time. So we have to think of this aspect. And there's another reason for why we should sort of focus on treatment as well. That is that vaccines may not be able to prevent transmission 100%. Actually, even now the data shows that there is some benefit. There is partial blockage of transmission, but we do not know exactly to what percentage. It may be around 50%. So transmission would still occur. Now, the risk of that is that our hospital systems can get really, health systems can get really overwhelmed. Now, imagine if there is increased transmission and a huge wave of infections, there'll be a percentage of patients needing hospital care, ICU beds. So that's going to compromise the health system a lot. So we have to actually prevent patients with mild disease progressing into severe disease. So we have to refine our treatment. So even in this vaccine era, COVID treatment is an essential thing, and we have to concentrate on that. Now, if you look at COVID-19, I think we all know that most patients, up to about 80% of patients, are actually do not have severe disease, and they can be managed easily, sometimes without any interventions as well. It is said that about 30 to 40% patients are actually asymptomatic, and then another 40% of patients may have mild to moderate disease, which doesn't need much intervention. But 20% of people may need hospital admissions. And out of that also about 10% will have critical disease, and about 5% of patients will need ICU care. So what we have to concentrate on is severe COVID. So severe COVID-19 is basically, it's a severe pneumonia, but it doesn't stop at that. The problem is that it causes lots of other complications. For example, now pneumonia could lead to ARDS, which is uh, quite a critical development, and these patients will need mechanical ventilation. And actually, patients with COVID-19 are sort of in a separate class, in the sense that they need a prolonged period of mechanical ventilation when you compare them with, say, a patient who has influenza and who needs ventilation. So it's a huge burden on the health system. Then the virus can actually directly attack organ cells. Now, we know very well that it can cause myocarditis, it can cause acute kidney injury, and those are brought about by the actual damage caused by the virus to organ tissue. And then there is this term cytokine storm, which is a situation where a patient with COVID-19 goes into a state of immune overdrive. And then there is an extreme inflammatory response. And because of that, there is a cytokine storm. Now, this does not happen in all patients. So we have to realize that it's not in all patients that this happens, but when it is there, we have to detect it early and treat. Then another peculiar problem with COVID-19 is that it causes thrombotic complications. Now, other viral infections can also cause, but here in COVID, it's a very well-known thing. And patients can present with acute myocardial infarction, acute stroke, deep vein thrombosis, and pulmonary embolism. It is said that it's the extreme inflammation that leads to this prothrombotic state. And then, of course, we all know patients with viral pneumonia can develop secondary bacterial and fungal sepsis. So that is also seen in patients who are on ventilators for long. So this also contributes to the mortality. So as you see, the point I want to drive home is that COVID-19 patients are not similar. I mean, no two patients are alike. They have different complications, different issues, and that is actually the challenge. We have to sort of assess each patient individually and fine-tune the treatment. That is why the focus on treatment is essential. Now, from this slide, we can go on to an outline of the strategies for management. Now, in this talk, I will not be able to cover each management step in detail, but we should sort of have a broad outline. So one, of course, as I said, it's a pneumonia, severe pneumonia. So innovative oxygenation and ventilatory strategies are important, and they have to be applied precisely at the correct time. And there should be antivirals targeting specific therapeutic windows, like say one antiviral may be optimal in a certain window during a certain stage of the disease. And another antiviral may be more beneficial later on. So it's an sort of a patient-tailored decision. And then immunosuppressive agents to counter the cytokine storm and the hyperinflammatory state, and anticoagulants to prevent and treat thrombosis. Then convalescent plasma to provide neutralizing antibodies, and synthetically derived monoclonal antibodies. Now, these two aim to neutralize the virus. Now, we all know once a virus gets into the body will mount an immune response, but it takes time. And during that time, the viremia can be so severe that the immune system could be overcome by the virus. So what we aim by giving convalescent plasma or monoclonal antibodies is to give the body that breathing space, give those to antibodies to neutralize the virus to some extent until the body's immune system can take over. And appropriate antibiotics and antifungals and antiplatelet drugs when indicated. And of course, very important, general supportive care in the HDU or in the ICU. Now, this part I will not be able to deal with, but we all know we have treated viral pneumonias in our ICUs, in our HDU setups, so we have to fine tune the treatment. Now, getting on to the therapeutic options, the antiviral that is mostly promoted is IV remdesivir. I will try to give a bit of historical background to its use. Now, its in vitro efficacy is well established. So it went on to trials, and it was actually used in Ebola, but only with partial success. And the issue has been that the trials have shown mixed results. It's widely used in the US, and it's used mainly in hospitalized patients with severe disease once they become hypoxic. A usual dose would be 200 milligrams IV on day 1 of IV remdesivir, and that is followed by 100 milligram daily for 5 to 9 days, for 4 to 9 days. Now, the one other drawback is that the studies have not actually evaluated its use in early disease. Now, the whole idea of giving an antiviral is to prevent disease progression. So, unfortunately, in most of those trials, the patients were brought to hospitals when they were hypoxic in the West, especially in the USA and in the EU. So, patients were already having severe disease when remdesivir was started. Now, FDA in the US gave approval for IV remdesivir based on a trial which showed that it actually lessened the hospital stay. Now, this was actually the paper they published in the New England Journal of Medicine in November, and it was based on a study of about 1,062 patients, and who were randomized to receive remdesivir in one arm and the standard care in the other arm. Now, if I just try to show you, now in the y-axis is the proportion that recovered, and in the x-axis it's the number of days the hospital stay. So you could see clearly that in various patient groups, those who were receiving oxygen, those who were on ventilation and so forth, in various groups, it was shown that the use of remdesivir has actually reduced the number of days of hospital stay. Not by much, and they conclude that it was by about 4 to 5 days. So it was not a very huge benefit that was shown, and there was no survival outcome. So I mean, in the study they had sort of assessed the hospital, the duration of hospital stay. So the study came in for criticism as well because of that. But their conclusion was that, I would skip this. I mean, this also shows the same thing. So the conclusion they drew from that trial, which was named ACTT1 trial, was that remdesivir is superior to placebo in shortening the time to recovery in adults who were hospitalized with COVID-19 and had evidence of a lower respiratory tract infection. So, I mean, this trial led to widespread use of IV remdesivir in the US, but it was not it was not followed to that extent in the EU or globally. And one other major issue with remdesivir is the cost. So most countries would not be able to afford the cost of remdesivir. Now, that study was actually contradicted by another study which was done by the WHO, and there is the Solidarity Trial Group, and they published it in the New England Journal of Medicine, and they actually studied a large number of patients. Now, remember in the previous study, only about 500 patients received remdesivir, but here they had randomized about 2,750 patients to receive remdesivir, 954 to receive hydroxychloroquine, 1,411 to lopinavir, and then another number uh, uh, was sort of not given any trial drug. And the conclusion that they drew was that remdesivir, hydroxychloroquine, lopinavir, and interferon had little or no effect on hospitalized patients with COVID-19, as indicated by the initiation of ventilation, duration of hospital stay as well. So here the study says that even the hospital stay was not lessened by remdesivir. So based on this, actually, remdesivir fell out of use in UK and in EU, but I think in the States it's still used as an antiviral agent. Now, by far the most important drug in the use in the treatment of COVID-19 is steroids. Now, IV dexamethasone, methylprednisolone, and hydrocortisone, they were used globally and widely as well from the beginning, but it was not based on trial data. The physicians treating those patients thought that because of the high degree of inflammation, steroids should help. It was the first proper trial that came out was the recovery trial group from Oxford, UK, and they clearly showed that dexamethasone given at a dose of 6 milligrams IV or oral to patients needing oxygen had statistically significant mortality benefit. Now, that's what we are all interested in. I mean, lessening of hospital stay is well and good, but ultimately it has to be the mortality benefit, and that's the parameter, the outcome that shows that a drug is effective. Now, the interest in dexamethasone is especially because of the low cost and the wide availability. Even in Sri Lanka, we are able to produce that, and we have large stocks. So it was actually a breakthrough in the management of COVID-19, a simple therapeutic method which could be adopted universally without any issue with the cost of management. Now, that was based on this trial by the recovery group. They published it again in the New England Journal of Medicine. And here actually a total of over 2,000 patients were assigned to receive dexamethasone, and there were about 4,000 for usual care. Now let's look a little bit into this. Now here in these plots, you can see that in the y-axis is mortality. So we are directly assessing the mortality, and by using dexamethasone across patient groups, there was a reduction in mortality, and the p-values were significant. In the order of 0.001. So that's quite significant. One thing that I would like you to note is that when dexamethasone was used in patients who were not on oxygen, then the p-value was not significant. So it was especially beneficial in patients who were on oxygen, who needed oxygen. So that's an important thing, because now some of our patients, when they are treated in hospitals, they may not initially have hypoxia, and at that stage we should not use dexamethasone. It's only when they turn hypoxic that we should use it, and that is backed by this recovery trial data. So their conclusion, it's worth concentrating on this, is that in patients hospitalized with COVID-19, the use of dexamethasone resulted in reduced 28-day mortality among those who were receiving either invasive mechanical ventilation or oxygen alone at randomization, but not among those receiving but receiving ventilator support. Yeah. So, I mean, basically, I think what we have to, I mean, if I simplify the conclusion, what they said, what they meant was that we should use dexamethasone in hypoxic patients, but not in patients who are not on oxygen. But of course, those patients should be followed, monitored carefully, and the moment they turn hypoxic, we should start dexamethasone. Now, I briefly told you about convalescent plasma in COVID-19. Now, uh, plasma from patients who have recovered sorry about that, recovered from COVID-19 was used to treat acute infections in others. As I said, there is some time taken by the body to develop an immune response. So within that period, if we use convalescent plasma, theoretically at least, it should benefit these patients. So this convalescent plasma has been used in other infections in the past it's been used in SARS, then MERS, H1N1, H5N1, and even in Ebola. Now, so the aim is to use the neutralizing antibodies in the convalescent plasma to counter the virus until the specific immune response in the person gets established. Now, ideally, the plasma that we give should contain a high titer of antibodies and should be given early on in the illness, maybe within the first 3 days. So that is something that's difficult to achieve. So US FDA has given emergency use authorization to convalescent plasma. Now, if you look at the studies that have come out, now there was a randomized clinical trial in the New England Journal of Medicine on the use of convalescent plasma. The patients enrolled were now the symptom, the median duration from symptom onset to enrollment was actually 8 days. So that was quite late. And there were 228 and 105 respectively in the convalescent plasma and placebo arms. And the median antibody level in the plasma was 1 in 3,200. So that was a significant hit actually. So the primary outcome was clinical status at 30 days. Now, mortality in the two arms were not significantly different. But then I think we have to argue out and say that the plasma was given rather late in the illness, not within the first 3 days that as was recommended. So it was given after 8 days. So probably the mortality benefit was not shown because of that. Then there was another trial, Indian trial, named Placid, which they published in the BMJ. And that there, 2 doses of convalescent plasma were given, 200 ml of convalescent plasma were given 24 hours apart. Now we get convalescent plasma from these patients after about a month from the initial disease of the donor. So they have to have recovered very well. So it's generally after 28 days that we harvest the plasma and then we give that to a person who's infected new. So the main outcome assessed was all-cause mortality at 28 days or progression to severe disease. Again, in this study, there was no difference between the two groups. There have been different studies globally. Some have shown some benefits, some haven't. But one good thing about convalescent plasma is that it's generally safe with less than 1% of adverse events. So still it's being studied in various trials. Now, monoclonal antibodies in COVID-19. Now, this is actually an attempt to give a synthetically produced antibody as an infusion early on in the illness. Now, several agents have been given FDA approval. Now, one is called bamlanivimab, and that's directed against the spike protein. And now these are given to patients who are thought to have a high risk of progression to severe disease. Now, they may be patients with lots of comorbidities. So there is a risk assessment done, and it is actually given in an out of hospital setting, in an OPD setting. so very expensive. So given as an infusion, so the aim is to give it early and neutralize the virus, something similar to convalescent plasma, but more, maybe more targeted. Now, you may remember President Donald Trump also received a cocktail of monoclonal antibodies, and it's these two agents, the combination of casirivimab and imdevimab, and given the name REGN-CoV2, and that is supposed to reduce viral load and symptoms in non-hospitalized patients. So could be also given as post-exposure prophylaxis. It's not widely used, but it could be used in certain specific situations where especially one would want to prevent disease progression in vulnerable individuals. Of course, the cost is quite huge, and I don't think we would be able to afford this treatment. Now, another important area is anti-inflammatory therapies. Now, we have all heard of the drug called tocilizumab, which is used in Sri Lanka for patients with severe rheumatoid arthritis. Now, it's an anti-interleukin 6 inhibitor, and it's used in this specific situation called the cytokine storm. Now, there is what we call macrophage activation syndrome, and tocilizumab is supposed to counter that well. Now, there was an article in the NEJM in early January where they had used tocilizumab in hospitalized patients with COVID-19 pneumonia with some benefit. And there is another interleukin 6 inhibitor called sarilumab that is also used. And there are other anti-inflammatory drugs, IL-1 inhibitor, anakinra, then JAK inhibitor, boricitinib. Now, this drug is an oral drug. So it's used with the IV remdesivir in the US, again, not widely used. But these therapies could actually complement the use of IV dexamethasone. I mean, these are all additionally to IV dexamethasone, IV oral dexamethasone. So that is important to remember. Now, this is that study that was published in the NEJM. So it said that there was some benefit of using tocilizumab, and the likelihood of progression to mechanical ventilation or death was a little less. But, and further on this matter, there is another, actually the recovery trial group in one of its preprints, which is of course not still peer reviewed and not published in a journal. They said that they had used tocilizumab in the recovery trial, and they found that when it was used in hypoxic patients who had a high degree of inflammation, which was gauged by the CRP level. If the CRP was over 75 and there was hypoxia, then they used tocilizumab, and the conclusion they drew was that it had a survival benefit. But of course, since it's a preprint, I didn't get a slide on that, and we have to wait for published data. But we can say that tocilizumab is beginning to show promise, and I think it may well come into guidelines later. Now, another important thing is anticoagulation in COVID-19 patients. Now, remember, we discussed this issue of the extreme inflammatory response. So extreme inflammation leads to a prothrombotic state. So these patients can have thrombosis in different parts of the body. So now, actually, a post-mortem study done in Italy in the early part of the COVID outbreak showed they had actually analyzed about 22 cases. And they found only about 4 or 5 cases of pulmonary embolism in that number, but about 15 patients. So most of the patients had microthrombi in the lung. So actually this alerted the clinicians to the possibility of thrombosis playing a big role in the morbidity and mortality of these patients. So in hypoxic patients needing oxygen, low molecular weight heparin, enoxaparin, is started uh, at a prophylaxis dose to prevent venous thromboembolism. Now, a usual dose would be something like 40 milligrams of enoxaparin subcutaneously daily. And of course, if there's renal impairment, if the GFR is less than 30, then that can be reduced to 30. But in patients who have severe renal disease, who are in end-stage renal failure, they will need unfractionated heparin and not molecular weight heparin. Now, once the patient is monitored, and if we find that the D dimer is over 1,500 nanograms a milliliter, or if the TEG, the thromboelastography, is consistent with a hypercoagulable state, or even if there is very strong clinical suspicion of VTE, then the enoxaparin preventive dose is converted to a treatment dose. So that is an important fact to remember. Again, depending on the renal function, the dose can be adjusted. And once the patient recovers and when we send the patient home, we have to assess the risk of VTE as well. And it's an individual, it's a decision based on individual patients. So some may need follow-up anticoagulation. Aspirin in COVID-19. Now, aspirin is a drug that we use in lots of instances, and it is postulated that aspirin could reduce the thrombotic complications of COVID-19. Now, there was a study done in the University of Maryland, and it was published in the journal Anesthesia and Analgesia, where they compared 98 patients who were on aspirin either 1 week before hospital admission, or who were started on aspirin within 24 hours of admission. And the results were actually quite promising. They showed that in the aspirin arm, patients were 43% less likely to need ICU care, 44% less likely to need invasive mechanical ventilation, and 47% less likely to die in hospital. So those are very important, very striking figures. But the only thing is, this was an observational study. So we need proper randomized clinical trials to show us that aspirin is beneficial. Now, in another study, which was done in Wuhan, China, and published in the Journal of Cellular and Molecular Medicine, the use of aspirin did not influence the outcome of COVID-19 patients. So there is conflicting data, but again, these are observational studies. So we need a proper randomized clinical trial. And it's interesting to note that the recovery trial group, which has given us very important studies in the past, they have now started an arm where they are going to use aspirin in a RCT setting. So hopefully they will be able to publish their results, and we will have more data. Now, these studies done on aspirin actually made a change in the Sri Lankan guideline as well, where in Sri Lanka, when patients have a high cardiovascular risk, we do start them on aspirin once they are hospitalized, because we know most of the patients are, once they're detected, they are monitored in various settings. So aspirin is given to patients with high cardiovascular risk. There's been some recent interest in ivermectin in COVID-19. Now, ivermectin has high in vitro activity against the SARS coronavirus 2. Actually, the activity level of ivermectin is much more than that of hydroxychloroquine. It has been used in some small randomized clinical trials and some observational studies as well. And there was some interest generated in a study that was published in the journal Chest. The study was done in Florida, and it had shown that in the ivermectin arm, there was a significant reduction in mortality, but it was also noted that the patients who had received ivermectin had received high percentage of those patients had received steroids as well. So it was difficult to assess whether it was the steroid effect or whether it was ivermectin that was showing the benefit. small randomized trials from Egypt, Iraq, and other countries have shown some benefit. Now, this actually prompted the US FDA to state that there is insufficient evidence to recommend for or against the use of ivermectin for the treatment of COVID-19. Now, previously, the US FDA said that there was no evidence at all, and their recommendation was not to use. But here they say there's insufficient evidence, so they may be thinking, they may be awaiting the results of RCTs that are in progress at the moment. But WHO says that ivermectin should not be used as of now, since the trial data is not there. Now, the important thing now is for us to consider what we do in patients with COVID-19 in Sri Lanka. Now, remember, the Sri Lankan policy is to isolate all patients with who are positive for COVID-19 based on PCR or validated rapid antigen test. So those patients are taken out of their homes and they are monitored in various settings. I mean, there are intermediate care facilities, then there are more advanced hospitals, and also specialized COVID designated centers where these patients are treated. Now, when a patient comes with a positive result, and when they are started to be monitored, one thing that we do is we give low dose aspirin in adults with high cardiovascular risk. And it must be stressed that patients who have severe COVID-19 and those with multiple comorbidities should be managed in designated specialized COVID hospitals like the IDH, Mulleriyawa, Homagama, and we have set up quite a few centers which are geared to manage severe COVID-19 patients. Now, there is a sort of a transition-like thing. Now, say a patient in an intermediate care facility, if the patient deteriorates, then the patient is quickly transferred out to one of those COVID-19 designated treatment centers. Now, the important thing for all of us to remember is that wherever the patient is, if a patient becomes hypoxic with a SpO2 of 94% on air, this patient should be started on dexamethasone. Now, that is very well established. It's based on trials. It's practiced in guidelines across the globe. So that is important. I'm stressing on this because some of these patients turn hypoxic not at COVID treatment centers, but at our normal hospitals. So when they are first detected, it takes a bit of time for patients to be transferred out. So until then, if a patient becomes hypoxic, we should promptly act and give dexamethasone, because that may save his or her life. So that's an important point that I have to stress. Then, of course, prophylaxis with enoxaparin is given in any patient who turns hypoxic. Now, when the patient has increasing oxygen need, obviously the patient will have to be transferred out to an HDU or maybe even the ICU. So the important message I want to give is that various oxygenation strategies are used to prevent the need for ventilation. Now, this is important because when COVID-19 broke out about a year ago, initially people were a little hesitant to use some of those methods like NIV, but now they are well established, and most of these patients do recover, and they recover with non-invasive ventilation. So a few strategies that we use are high flow nasal oxygen, which is available in Sri Lanka, then non-invasive ventilation, various strategies with CPAP, BiPAP machines. And also must be mentioned about this procedure of proning. Now, proning is patients are, even if they are hypoxic, they can prone to a certain extent, and even ventilated patients are prone actually. So proning is a method to recruit areas of the lung which can facilitate gas exchange. Now, remember we talked of microthrombi, so because of perfusion abnormalities, certain areas of the lungs may not be able to take part in the gas exchange well. So by proning, we try to overcome that. Now, details of this I have no time to go into. I think critical care of a COVID-19 patient is a topic in itself, so we probably will have to deal with it on another day. And the other important thing is, if we do suspect that there is a possibility of VTE, then we do have to convert the preventive dose of enoxaparin to a treatment dose. Now, invasive mechanical ventilation should be instituted without any delay if a patient needs it. Now, even with those non-invasive strategies, if we find that the ARDS is not improving, then we have to immediately start invasive mechanical ventilation. Now, one special aspect of ventilating patients in COVID is that they need prolonged ventilation. That's why the ICUs get blocked for days, for weeks and weeks. And some of these patients may need ventilation beyond even 1 or 2 weeks. So it's an unusual situation where in other viral pneumonias, we usually manage to wean these patients off much sooner. So dexamethasone, once started, is continued for 10 days. So we give either IV or oral. Of course, in some patients, IV will be needed. Now, the supportive care in the ICU is very important. Now, I can't go into details. So that's one very important thing, because even before all these treatments came into practice, actually in most of the ICUs around the world, they brought down mortality by fine-tuning supportive care. So that's an aspect we really have to stress on. So that is basically the what I want to discuss. One other point that I want to highlight is that patients are found in various hospitals, and until they are transferred out to designated centers, the ideal management of those patients should be started. So that is important. Otherwise, a delay could mean that we may not be able to salvage the patient. Thank you, and I'm happy to answer your questions if you have any.
If you have any questions now, you can unmute your mics and ask the question. Okay, it seems like there are no questions. So now I would like to call upon Dr. Uday Gunawardena, Assistant Treasurer of the Society for Health Research and Innovation and the Executive Committee member of the Government Medical Officers Association, to present the token of appreciation to Dr. Harsha Satish Chandra.
Before that, I think I just detected a question on the chat. The question is how to treat sinusitis in COVID. Is it okay to start on low-dose dexamethasone? Yeah, I mean, for sinusitis per se, we don't give dexamethasone, but of course the general management is, steam inhalation, reducing nasal congestion, all that would be helpful. But that sinusitis per se is not an indication to start on low dose dexamethasone unless, of course, there are specific issues with swelling of vocal cords and all that. So if that happens, then of course there is a place. Then there is also a question about HRCT changes in COVID. Yeah, actually, yeah, true. Yeah, there are specific changes where the lung is involved mostly peripherally and basally. It's usually bilateral, but can be unilateral as well. But the involvement is peripheral and basal, and there will be ground glass appearance initially in the CT. But of course, as COVID goes on, can lead to a fibrotic lung disease, and those changes will be seen. So the whole idea of treating these patients aggressively is to prevent fibrosis in those who survive.
Another question, sir. They are asking
Yes.
any specific diet for COVID-19 patients? Any
Any
specific
specific
diet?
Yeah. Not exactly. There isn't a special diet as such. I mean, we would want them to have the norm, have good nutrition. They may be sort of asking us about foods rich in sort of vitamin D and zinc, maybe like that. Well, I mean, in that stage, once you've got COVID-19, vitamin D and zinc, those will not really help that much. Studies have not shown any clear benefit. So a good healthy diet with good nutrition is important, and of course it has to be said that a good fluid intake has to be maintained in these patients.
There's a specific treatment, giving vitamin D3 for COVID patients, sir?
No, vitamin C has not been
vitamin
shown
D,
to.
sir.
Vitamin D.
D3.
Yeah, vitamin D. Yeah, vitamin D. I mean, there are lots of studies that have been done in various countries. What actually people thought was that now when there's vitamin D deficiency, there will be a level of immune deficiency. So those patients, whether these patients are more likely to catch COVID-19 than others who are vitamin D replete is another aspect. Even that has not been established. Now, one thing to remember is that vitamin D levels are low in patients who have diabetes, who are obese, and it's actually in those obese patients and diabetes patients that the COVID-19 clinical course is severe. So we do not know whether by doing a vitamin D level when they come into hospital, whether we can sort of draw any conclusion. So some argue and say that there have been a few studies where they have shown that when vitamin D level was low, the clinical course of COVID-19 was severe. But maybe the vitamin D level was low, and vitamin D level was low in diabetic patients and in obese patients, and in those patients we anyway know that the clinical course is severe. So no clinical trial has established that giving high dose vitamin D or vitamin Z or zinc to patients who already have COVID-19 is of any benefit.
There's another question, sir. What are the hematological changes in COVID in full blood count and liver function tests in the early of the disease, sir?
Yes. Now, the one particular thing about COVID-19 is that when patients do come, initial blood counts may show a lymphopenia. Now, lymphopenia is the thing that sort of carries a poor prognosis in COVID-19 patients. So the white cell count may or may not be abnormal, but there could be severe lymphopenia. Actually, some of these patients initially can even have a high white cell count, but lymphopenia is seen. And with regard to liver enzymes, they can be elevated. So, and there are various other things, serum ferritin levels, serum LDH levels. When those are high, those carry a bad prognosis. But of course, I mean, those are not the only criteria that we depend on. We have to assess the clinical status of the patient to say whether the patient is having a having severe disease or not.
There's another question. There's from GP sector. They are
Yes,
asking these days in GP sectors as well as OPD sectors, there are a lot of patients coming with sinusitis, headache, and fever. Then they are asking how to differentiate from with this prevalence, how to differentiate it from COVID. They say when they come to the GP practice, because earlier they have sent most of those patients during those days for COVID centers for treatment
yes,
with headache and sinusitis because they are more suspicious on COVID. Because
yes,
the
yes.
prevalence is low, they are asking how to differentiate whether COVID or any other sinusitis like common respiratory tract infection, upper
Yeah.
respiratory infection.
Yes, I get your question. Yeah, it's a bit difficult now. This is in a pandemic time now. Say we have to suspect COVID-19 in all patients who have respiratory symptoms. Now, particular symptoms of COVID-19 are fever, and then they can have shortness of breath, and maybe even symptoms like anosmia, loss of smell. So those are particularly seen with patients with COVID-19. It's little unusual to see patients who are sort of pouring out from their nostrils. So that kind of thing is like features of a common cold. So that's a little different to what we see in COVID-19. But then COVID-19 patients have also been, I mean, they can be asymptomatic and they can have very mild symptoms. So clinical differentiation is not easy, but I suppose any patients with fever, then headache, shortness of breath, a dry cough. I mean that should ring alarm bells in you. But if you have any suspicion, I think we have to subject them to a PCR test. Now, actually, when a patient has COVID-19 like symptoms, it is you can do the antigen test, but even if the antigen is negative, you're supposed to do a PCR test as well, because I mean the sensitivity of the antigen may not be very high. So that's important. So clinically you can't differentiate 100%. Maybe, I mean, say if a patient has more cold-like symptoms without fever, without cough, without shortness of breath, that may be a respiratory infection. But during this time, you have to make a clinical decision and maybe assess their risk of exposure as well, and subject them to the appropriate tests.
There's another question, sir. Up to which
Yes.
day of illness will the rapid antigen test will be positive? Up
Yeah.
to which day?
Now, the antigen test will become positive when the viral load is high. So generally, we say the viral load is high 2 days prior to the onset of symptoms, and then for about 5 days after that. So let's say within the first week or so of the illness, the antigen test has a high chance of showing positivity if it is actually COVID. But after day 7, when the viral load goes down, the antigen may not be a sensitive test. So in that situation, PCR will have to be done.
So there's another question. What are the long-term complications following COVID after recovery?
Yes, now there has been a lot of talk about this. I think one complication that could occur is, of course, in a patient who had severe COVID-19, who was in the ICU, who was mechanically ventilated for long. I mean, some of these patients can have lung fibrosis, so they may continue to have, even after discharge, shortness of breath, fatigue, and all that. So that's possible. And actually, they have been in England. They have started a large study where they are going to follow up all these patients, thousands of patients, to see what complications they could have. There have been talk of various neurological complications as well. But they are not very well established. But hopefully this large study in the UK will show us exactly what complications are there. With regard to patients in Sri Lanka, I think we've met some of them. Well, what we see that most patients recover very well, but of course, long-term effects still we will have to assess and see.
Here's another question, sir. If the
Yeah.
CT value is more than 30, with positive
Yes.
PCR, is he still spreading the disease at that
Yeah.
time also?
Yeah. So this CT value, now we know CT value, when the CT value is high, what it implies is that the viral load excreted by the patient is low. So if the CT value is low, the viral load is high. So if the CT value is over 30 or 32, the chance of this patient the viral load must be low, and the chance of this patient being infective is much less. Now, actually, say what we normally say is that now once we get COVID-19, the illness goes on. It's usually patients who recover, they recover within about 7 days. So day 7 is the cutoff where patients either, they improve and go home, or they get severe disease and they become hypoxic and, they need hospital admission. So once a patient recovers after day 7 or day 10, usually they are not infective, and lots of studies done worldwide have shown that replication competent virus has never been found in any patient who's discharged after day 10 once they clear their symptoms. Now, of course, if they have symptoms going on, then it's a different matter. Then, of course, the PCR, we may not be able to go by one value. The other issue with the PCR is that, it can be variable. There can be variable viral excretion. So PCR can be positive one day, can be negative later. But generally, in patients who recover well clinically, after day 7 or day 10, by day 7 or day 10, they become non-infectious. And but patients who are, let's say, in ICU, who are receiving ventilation, and who have a prolonged course of illness, they can be positive. And that is why in the Sri Lankan discharge strategy, we do discharge patients after about 10 days if they are completely clinically well, sometimes even without a PCR test. But patients who have a longer course of illness, they will need a PCR test before discharge. Now, so the CT value of over 30 will definitely will indicate that the chance of the patient being infective is much less.
Then the other question is impact of the infection to the fetus within third trimester. What is the impact of the COVID infection to the fetus during the third trimester?
Yeah. Now, now data has on this has been a little conflicting. Initially, I think the recommendation was to treat pregnant patients with COVID-19 the same way we do for the patients. In fact, it was said that probably COVID-19 has less of an effect on pregnant ladies compared to influenza. But pregnancy is still considered a high-risk category, so we have to assess the patients. I don't think that there have been studies, like say, published in the medical literature of the impact on COVID-19 on the fetus. But of course, the issue is now, say if a pregnant lady has COVID-19 in the third trimester, and if the disease course in the patient is severe, if the patient has severe inflammation, if the patient has severe thrombosis, then of course effects will be there on the fetus.
Right, sir. Thank you very much, sir.
Yeah. Thank you.
Now I call upon Dr. Uday Gunawardena to present the token of appreciation to Dr. Harsha Satish Chandra.